Scoliosis outlines normal vertebral curvature, definition, types, non-structural or structural, clinical features, imaging, treatment, conservative and operative, summary. Normal spine. Primary curves are the natural curves in the spine that we are born with. Thoracic and pelvic curves. Compensatory curves or secondary curves develop after birth in response to learned motor skills. Cervical section. Infant learning to hold his or her head upright and learning to sit unsupported. At 3 to 4 months of age, lumbar lordosis. Lumbar sections begins to develop as a child learns to walk. Two components: abnormal side to side curvature of the spine, deviation from normal vertical line, at least 10 angulation, vertebral rotation, pedicle position, 0, no rotation, plus 1, pedicle toward midline, plus 2, pedicle two-third to midline, plus 3, pedicle in midline, plus 4, pedicle beyond midline. History, family history, recent growth history, sexual maturity, menses, pain, fatigue pain, post diagnostic pain, severe pain. Clinical features: obvious skewed back, rib hump in thoracic curve, asymmetry prominence of one hip, thoracolumbar curves, skin pigmentation. Look for congenital abnormalities, scapula level, breast and shoulder level, lower limbs length, cardiopulmonary function. Adam's test. Bend forward. Scoliometer measures angle of trunk rotation. 98% of curves more than 20 have angle of trunk rotation of at least 5. Fairly high false positive. High sensitivity, low specificity. Cobb's angle. Maximal angle from the superior end plate of the superior end vertebra to the inferior end plate of the inferior end vertebra. Major factor in the clinical decision making process. Curve progression less than 30 will not progress after skeletal maturity, 30 to 50 progress 10 to 15 in lifetime, more than 50 progress about 1 per year, more than 90 affect cardiopulmonary function. Reser's sign iliac apophysis, ossification from lateral to medial, starts ossify shortly after puberty. Skeletal maturity curve progresses the most during period of rapid skeletal growth. When fusion complete, spinal maturity has been reached, coincides with fusion of vertebral ring apophysis. Further increase in curvature is negligible. Stage 5. Postural scoliosis. Deformity is secondary or compensatory to some conditions outside the spine, non-structural or compensatory. Short leg, pelvic tilt due to contracture of the hip, local muscle spasm associated with pelvic inflammatory disease, sciatic scoliosis. Sit or bend forward, usually, usually temporary and disappears. Treat underlying cause. Structural scoliosis, three types: idiopathic scoliosis, neuropathic, and myopathic scoliosis, congenital scoliosis. Idiopathic scoliosis, three types: infantile, 0 to 3 years old; juvenile, 4 to 9 years old; adolescent, 10 years to maturity. Congenital scoliosis, present at birth, usually is due to a deformity in one or more vertebrae associated with other congenital anomalies. Overlying tissues, angiomas, navy, excess hair, dimples, fat pad, or spina bifida. Clinical examinations and imaging to discover other congenital anomaly, to assess the risk of spinal cord damage, example, cord tethering, which must be dealt prior to curve correction. Defects of segmentation, block vertebra, unilateral bar, defects of formation, hemivertebra, wedge vertebra. neuropathic and myopathic scoliosis, diseases, cystic fibrosis, various types of muscular dystrophy, spina bifida, cerebral palsy, Marfan syndrome, rheumatic disease, myelomeningocele, tumors, deformity of the spine, often severe in patients with neuromuscular scoliosis. The greatest problem, loss of stability and balance, sitting difficulty, X-ray with traction applied shows extent to which the deformity is correctable. Idiopathic scoliosis. 80% of all scoliosis. More than 10-degree curve. No identifiable cause. Three different groups: infantile, 0 to 3 years old; juvenile, 4 to 9 years old; adolescent, 10 years to maturity. Simpler division: early onset, before puberty; late onset, after puberty. Infantile idiopathic scoliosis. Males, most curves spontaneously resolve. Surgical intervention can result in significantly shortened trunk. Juvenile idiopathic scoliosis. 12 to 21% of idiopathic scoliosis, 3 to 6 years, male equal to female; 6 to 10 years, female ratio male 10 is to 1. Curve progression is common. 70% require some form of treatment. Late onset, adolescent. Primary thoracic curves are usually convex to the right. Lumbar curve to the left. Intermediate thoracolumbar and combined double primary can also occur. Curve less than 20 degree either resolve spontaneously or remain unchanged. Predictor for progressions. Very young age, marked curvature, an incomplete research sign at presentation. In prepubertal, rapid progression is liable at growth spurt. Warning signs prompting extensive evaluation. Convex left thoracic curve, severe large curves in very young children, scoliosis in boys, painful scoliosis, sudden rapid curve progression in a previously stable curve, extensive curve progression after skeletal maturity is reached, abnormal neurological findings, small hairy patch on the lower back, treat or not to treat, bracing, observation, surgical intervention, prevent mild deformity from becoming severe, to correct an existing deformity that is unacceptable to the patient. Non operative treatment, bracing, treatment of progressive scoliotic curve 20 to 30 degree, where 23 hours and does not prelude full daily activities including sports and exercise. Milwaukee brace, thoracic support, pelvic corset connected to adjustable steel supports to cervical ring carrying occipital and chin pad. Purpose to reduce lumbar lordosis and encourage active stretching and straightening of the thoracic spine. Boston braces, sug fitting underarm brace that provided lumbar or low thoracolumbar support. Problems with braces, argued efficacy. Most orthopedic surgeon waits until the curve progress to the stage when corrective surgery is justified. Narrow treatment window to initiate. Bracing will not improve the curve, stop it from getting worse. Bracing has not proven to be effective for older adolescents. Poor compliance, must have good orthotist. Proper education, how and when. Surgical indications, curve more than 30 degree that cosmetically unacceptable, especially in prepubertal children who are liable to develop marked progression during growth spurt. Milder deformity that is deteriorating rapidly. Objectives to halt progression of the deformity, to straighten the curve, including rotational component, to arthrodese the entire primary curve by bone grafting. Anterior fusion, single rod, double rod. Posterior fusion, hooks, hooks and pedicle screws, all pedicle screws. Anterior fusion and posterior spinal fusion. Complications of surgery, neurological compromise, spinal decompensation, pseudoarthrosis, implant failure. Thank you.